Good day. I am Sherilyn Francis with the National Center for Primary Care, and we welcome you to part 4 of our 4-part Readiness for Adherence webinar series. At the NCPC, we invite you to connect with us via social media at Care Matters and at our website, www.primarycarematters.org. Today's webinar is brought to you by a partnership between the National Center for Primary Care at the Morehouse School of Medicine and Novo Nordisk. The NCPC is a national resource for encouraging doctors to pursue primary care careers, for making primary care practice more effective, and for supporting primary care professionals in serving underserved areas. The core principles of the NCPC are access, effectiveness, and equity. The terminal learning outcomes for today's presentation, actually for the entire series, are to list the national adherence rates associated with insulin and other injectable medications used by patients with diabetes, to describe the adherence problem with insulin and other injectable medications in racial and ethnic minority populations, to develop a diabetes action plan that will increase adherence in racial and ethnic minority populations, to describe health equity as not achieved as it pertains to macrovascular and microvascular disease outcomes in African Americans and Latino populations with diabetes, and to develop a medication regimen that is evidence-based and designed for African American and Latino populations with diabetes. I now present to you today's webinar entitled A Multi-Layered Approach to Medication Adherence for Vulnerable Populations, presented by Ms. Sabrina Jackson, Dr. Christopher Sean Holloway, Ms. Kati Shamos, and Dr. Best. In compliance with ACCME guidelines, the following presenters have no financial or other relationships with the manufacturers of any commercial service discussed in this educational activity. And now, Ms. Jackson.
Thanks so much, Sherilyn, for that introduction and orientation for our audience. I would like to just take a few moments to officially welcome our audience and extend a heartfelt thanks for you spending this time with us. For those of you that have been a part of this series over these 4 months, we really do appreciate you, particularly your comments and your questions that you've sent in. It's really helped to fuel this and to make it the success that it has been. And so I wanted to say that part of, you can go to the next slide, Sherilyn. Part of our approach today is going to be a little bit different. So for those of you that attended the other webinars, what we wanted to do this time is more of a panel discussion, and thus the title of the multi-layered approach. We thought it would be a good idea to really capture and begin to pull together some of the things that we've discussed over the last 4 months. You may remember that we started off saying that this is an ongoing conversation, and we really wanted to lay out this education activity in that way, that one thing builds on another, but we don't have all the answers. And it is very important that we disseminate information, but that we form connections so that those of us who are, and those of you who are those boots on the ground clinicians that are out there, that we are forming connections to continue to be able to support each other. I thought there was a slide that had our little group panel discussion idea on it. 2 of the things that we wanted to talk about, or the topic today, are going to center around 2 areas. One, we're going to talk about medication solutions for adherence issues, as well as some team-based approaches to dealing with medication adherence, particularly in minority population. This slide, I put this here just as a reminder of some things that we've talked about over the last few months, that when we talk about adherence, we need to understand that adherence is not just one medication problem. So it's not just not taking medicine. It also encompasses the idea of not taking medicine as prescribed. It encompasses the idea of omitting doses, of starting medicine and then stopping it, as well as not picking up medications on the proper regimen. So I did want us to keep that in mind, that when we use the word adherence, it's encompassing all those ideas. And this slide shows what you already know. Adherence is an issue, and it's not just an issue for racial and ethnic minorities. It's for patients really that are dealing with any chronic diseases. So And so when we began to approach one of the ideas of the questions when I looked over today, many of you asked the same question, well, what causes adherence? And I like to think about it just when we think about how diabetes is an individualized disease. There are many things that drive adherence issues for our patient populations. What is important to note from this slide is that there are things that fall into categories of both patients and providers. And so like I said, that it could be as individual as the patient, but when you look at the literature and you start to poll people in groups, you start to see a few things that are emerging. In terms of patient level, drivers, age could be one, but regimen complexity. Many of our patients that have diabetes also have other chronic diseases. And so trying to navigate medications for one disease and another and making all those things sync can be a problem. This idea of psychological insulin resistance, which we'll talk a little bit more about on the next slide, has a big impact in patients being able to adhere to their regimen. Safety and tolerance, of course, cost, perception and beliefs, patient-provider interaction, in looking at the dynamics that happen in the exam room plays a big role. And then for those of us who are caring for patients in underserved areas, social determinants. Those are those things that are impacting our patients every day outside of that exam room. But it's also important to note from this slide that there are some provider-led or some provider-level drivers. This idea of PIR affects us providers too, but also biases. Will my patient gain weight and further compound these issues? Are they going to have a problem with hypoglycemia? And does my patient have the proficiency to really be able to navigate using insulin with titration and making sure that they're dosing properly? Do I have the time? I'm sure if I put a poll question up now, the majority of my audience would say that time is an issue with trying to get it all in, seeing more patients in less time. Personnel, who's on my team that I can trust to do this or who has the time to do it. But also limited knowledge for me as a provider. Medications change so rapidly. That's why I'm so happy that we have Sean here, pharmacist, to keep us abreast. But sometimes things, as soon as we catch up with one, there's another one that's on the market. But not only that, but knowing some tips and tools and the best way to prescribe or to dose medication, so that also can be an issue with adherence. Next slide, please. And I want to spend just a little bit of time talking about the psychological insulin resistance. And it's really defined.
The next slide, we have a poll question.
Okay, sure.
So the poll question is, in your opinion, which is the primary driver for medication non-adherence for patients with diabetes?
You probably should have put that up before.
Approximately 50% indicated, or roughly 50% indicate patient-level factors as the primary driver. 47%, well, actually, is split between patient-level providers and provider-level drivers.
All right, awesome. So this concept of psychological insulin resistance has a lot to do with perceptions and belief. And for those of us who treat any kind of patient, it compounds anything that we are prescribing for them. If they have beliefs and thoughts about it, then you may not get past that. And so I thought this study was pretty interesting. This was done over about 4,000 patients. And so what they did was they divided them up, and all these patients were diagnosed with diabetes. They divided them up into two categories, those who were willing and those who were unwilling. The unwilling group was about 1/3 of those who were polled. And so these were the attitudes that patients reported that they had concerning insulin. What I wanted to point out is when you look at the unwilling and the willing group, that even those who were willing scored pretty high on some of these attitudes about insulin. And then when you look at particularly low self-efficacy, so most of the people reported negative attitudes about taking insulin. But one of the ways that they both scored high on was on personal failure, that people somehow felt that if I'm on insulin, I'm somehow being punished because I haven't managed my diabetes properly. And I put this slide here mainly to highlight the fact that that as providers, we need to be aware that this exists and go ahead and ask the question. Go ahead and bring up the issues that patients may be having so that it helps to lower their resistance to being honest with you. And like we all know, if it's there, it's going to show up. So go ahead and introduce it, open the door to give them the ability to say what their worries and what their concerns are. Many of them are myths and just generalized fears, which can be dispelled with education, with proper education. And I will venture to say, and maybe we'll talk a little bit more about this during our Q&A session, that there has a lot to do with trust, particularly when you're dealing with some racial and ethnic groups. Trust between patient and provider is a big deal, and they are a lot more willing to buy what you're selling if they generally trust you in terms of feeling that you generally care about them, or that you are a good source of the right kind of information. Next slide, please. And so as I conclude, and before I turn it over to Dr. Holloway, I just want to bring to light the pink elephant in the room, that our healthcare landscape in this country is changing. For those of us who are caring for the underserved, we are excited about that because we know that our patients will get quality care. But there's a rub because we've got to get there. And so in terms of now pay for performance, adherence issues are really our problems to solve. And so that brings to light why this webinar series was very, very important for us to have. And just to remind you that we are in it together, and we hope to offer resources and tools that help you get it done. So with that said, thank you, and I give you Dr. Sean Holloway.
Thank you so much, Ms. Jackson. Yeah, I'd like to echo what you shared earlier. I would like to thank our audience out there for being supportive and sending in your questions, and we hope we've answered your questions. If we have not answered your questions, please let us know, and we'll get those answers to you. And we hope that we have made a dent in eliminating disparities in racial and ethnic minority populations as it results to disseminating knowledge, hopefully that you value. So what I'm going to briefly talk to you about here today are really two things: is critique the practice of prescribing insulin to address poor outcomes. Do we have the right medicine on board that needs to be on board at the time, at that specific time? And that's a changing landscape. Okay, that's a changing landscape. And so, having said that, this is a table of medicines, daily oral medications that we use daily, insulin medications, and the newer agents, GLP-1 agonists, and also we have a SGLT2 inhibitor on there. And you can see the strengths and forms. But what I want to bring attention to is you'll see there are 3 medications on this list here that have a star by them. And those 3 medicines, glucophage, brand name metformin, empagliflozin, brand name Jardiance, and liraglutide, brand name Victoza. These are 3 medicines that reduce cardiovascular disease. And we all know cardiovascular disease is what kills patients with diabetes. Now notice, I think what is obvious, but none of these medications here are insulin, okay? None of these medications are insulin. And I think it all suffices to say the first line agent, according to the American Diabetes Association, is glucophage. It's a tablet. It can be given daily in extended release forms, which we see a lower amount of gastrointestinal problems that we see at a much higher rate with the immediate release tablets that are given twice a day. The great thing about glucophage, it's free at most Publix, the Walmarts, the Krogers, the other avenues. It's typically on for a 90-day supply. It's typically $10. And I just want to remind everybody that this reduces cardiovascular disease. Now, the other 2 agents that we have here, the liraglutide Victoza, it is given daily as a subcutaneous injection, and it is shown to reduce cardiovascular disease. It's only available in the pen form. It is a medication that may or may not be covered on some formularies, but that landscape is going to be changing as it relates to Medicaid in Medicare formularies because of the data of how that happens. The main problem, the unwanted adverse effect with the liraglutide thus far that we see is because it slows gastric emptying, is there can be some GI-related problems, and that's why we see the weight loss that's associated with using that. The next one, empagliflozin or Jardiance, is a tablet that's given daily that we've seen that it reduces cardiovascular outcomes. There's some problems that go along with that weren't expected in the clinical trials, and there's some black box warnings that are out there that's related to that, and for the sake of interest, we don't have time to go over those. But one of the things that we want to show you is that most of these medications here are daily or weekly medications. Okay. Now, what you'll see on most formularies, if they don't have the liraglutide on formulary, they'll have the exenatide, the Biduran, which is a dosing. Now, it hasn't been shown in the clinical trials because it was developed post 2008, but it's given weekly. It's given weekly there, and but it does not have that outcome. But the thought is, if it falls in the same category as liraglutide, we'd like to see that outcomes. But I haven't read any or evaluated any data that has shown that. What you'll also see here is some of the newer insulins, Degludec, which is Tresiba. It's a U100 pen, U200 pen that's given daily, and Glargine, which is Lantus. Next slide, please. So we said we're going to talk today about medication adherence, and we thank you for that, for your poll questions that's asked about medication adherence. And one of the questions, registration questions rather, was how do we measure adherence with insulin? And the answer is you can't. CMS and most insurance companies do not, because insulin is titrated up and down. Therefore, they cannot measure the adherence rate of that. But CMS and most insurance companies will measure adherence of your Victoza, your Biduran, your metformin, all other categories as 80%. What does that mean? How do they measure that? The way they measure that is adjudication claims from the pharmacy. When the patient picks it up from the pharmacy and goes home for the first time, that is not time one in terms of ticking. When they pick up the first refill, okay, going forward, that's when they measure adherence. And so what that means is that if you multiply 80% times 365, patients can miss 72 days of the year, okay, and that's it. And that's very important for everybody to understand, because it's not self-reported. These are adjudication claims that goes from the pharmacy to the insurance company or CMS, and then it comes back, okay? So the triply weighted measures from CMS, they're listed here for you for hypertension medications, which must include either an ACE or an ARB. And the reason that's important for our patients with diabetes is those have shown to delay nephropathy associated with diabetes, okay, consistently from the HOPE trial, which was published in 1999, moving forward. In the second category are diabetes medications that includes oral and injectable, but doesn't include insulin, like I said previously. So that's all the other medicines that are used for diabetes. And then the third category is your hyperlipidemia medications, aka the statins. Okay, they don't measure the LDL. Okay, they don't measure the LDL, but they measure adherence to the statin medications. Now, ironically, the other triple-weighted medication, the other triple-weighted measure is the A1C, and the last one, triple-weighted adherence measure, triply weighted measure is your blood pressure at goal or not. So you can see how that fits with the second point and the first point. But CMS does not evaluate if your LDL is at goal. So having said that, in the interest of time, any questions I'll be happy to direct at the end.
We do have a poll question. We would like to get a perspective from the audience on which strategies they most frequently employ when a patient is non-adherent.
Oh, that's a great question. Yeah, hopefully everybody will answer this if you can.
Here, we'll keep this poll open for a few more seconds.
Oh, wow. Very nice. If you could just load up the next slide for us, please.
Yes, we are having a brief delay in the slide transition.
Sure. Yeah, that is, I'll just speak a few seconds before the next slide comes up, but that's what we were hoping to see there, is the 90-day supply, because what that shows is that the patient only has to go to the pharmacy 3 times a year versus 11 times a year. And so one of the problems with access to care is transportation. And diabetes self-management and education, I think, yeah, we would all agree, as all the panelists, we would agree that the first thing to do, and this gets back to what Ms. Jackson was saying earlier, when people trust you with their lives, they are generally open to doing what you ask them to do. But if you don't have time or the ability to establish rapport with patients, it becomes really difficult. And that's what the heart of team-based care and diabetes self-management education class is, trying to gain that trust of the patient. And we see here at Morehouse Healthcare in Atlanta, we see when patients come to our group diabetes visits, we talk to them in great detail about earning their trust and buying into their care and their treatment plan. And if they're not on board with that, we dig down and we peel back the layers to try to figure out what would be a better care plan in their opinion. Mm-hmm. And then we try to explain the rationale of the care plan that was picked for them, specifically the pharmacotherapy, the mm-hmm. medications. And having said that, what we see is once those patients finish the group diabetes visit, they're certainly more motivated to doing what you would ask them to do, and their adherence goes up exponentially. And 3, their no-show rate for their appointment goes down significantly. And so the efficiency goes well for everybody. Yes, ma'am.
While we have some time, I thought maybe we could just have you answer a few questions while we're waiting for
Sure.
the slide issue to be worked out. This one will involve titration of insulin. How do you factor sliding scale insulin into calculating medication non-adherence?
Oh, okay. Well, 2 points. Remember, insulin is not factored in to calculating adherence. Now, mm-hmm. indirectly, we can tell if patients are adherent with their insulin, because if you follow the ADA standards of medical care that come out every January, you'll see now that when patients' A1C is above 9 and also above 10, they recommend starting insulin. That doesn't mean that we need to keep them on insulin. It just means how are we going to get them to their goal A1C less than 7. Insulin is the only medication that we can use to get them to their goal. And so what we can tell is in those patients, we can look at their fasting blood sugar, and we can also look at their A1C, whether they are adherent to their insulin or not. Mm-hmm. And if we still see that A1C, they say they're taking their insulin, A1C is greater than 10, we can generally tell they may be taking it, but they may be overeating because of fear of hypoglycemia. And at that point in time, we make an action plan, and we go step by step with that we go step by step with whatever patient-specific action plan we've created, with the key driver being exactly what Ms. Jackson said, and that's earning the trust of the patient. Okay, looks like we got the next slide up here. And this is the development of a patient-specific action plan. It segues pretty well. But some of the barriers that's seen and that's evaluated in the literature as it relates to racial and ethnic minority populations, as it relates to patients that live in medically underserved area, transportation is a big one. So if we can get their medications mailed to them, that's certainly helpful with that. If we've even started looking at the idea of partnering with Uber and Lyft it makes good sense if we can get patients to get their medicines, or if we can get their medicines to them, it's certainly worth looking at. An adequate day supply. Everybody, the poll response hit this right on the head. We want to give a 90-day supply of all your medicines for cholesterol, all of your medications for hypertension, all your medications for diabetes, whether it be the physician e-prescribing, whether it be the nurses calling in or e-prescribing refills for that. We have it as a standard practice in our clinic here. It's a 90-day supply. Education regarding the value of medicine. This is the heart of what DSME does. And you can look at the ADA, their recommendation level is a grade A level regarding diabetes self-management and diabetes self-management and education. Excuse me. Synchronization of refills. As pharmacists, we're starting to see this is very important. And what this means is that if you look at most patients with diabetes and hypertension, and typically hyperlipidemia goes along, at minimum, they're going to be on 6 different medicines. And so if we're going to go to that 90-day supply, it only makes sense that we sync their medicines to where they get all the medicines the same day when they go to the pharmacy. And that's what we mean by synchronization of refills. Now, those days for pharmacists, it can get pretty hairy. Trying to dispense all those medicines, and pharmacy technicians, it can get pretty difficult. But that's what we call setting our patients up for success. And then the last piece there is the mailing of medication, and that's a state-specific thing, okay? But the bottom line is we want to create a patient-specific action plan to overcome the barriers, and we want to keep that in their medical record. What was, when we looked at their adherence last time, it was this. What action plan did we create? Did the action plan work? If it didn't work, why did it not work? But you have to get the patient buy-in to that. And this sounds like it's a lot of work, but it becomes very intuitive with the whole team in a clinic if you're delivering team-based care, because it's the way everybody starts thinking. Okay. And the last bullet point is revisit the action plan when the blood pressure is not at goal and the A1C is not at goal, because it may mean non-adherence is the cause. Okay, and we need to figure out what's the barrier. And one of the things with our group diabetes visit, when we bring the patients in there and we kind of look at their adherence, then one of the first things we'll do is we'll ask them, what do you hope to gain from this group diabetes? Tell me the most important thing that you hope to gain here, and then the second most important thing. And more often than not, it's not adherence, and we'll ask them, tell us your thoughts about adherence. Is it important for you to take your medicine like your physician or physician extender prescribed it? And to try to get that dialogue going, we let them know that we care about them, we love them, we're not here to judge them. What we want to be an advocate for them, but we just need to know if they're taking their medicines or not. And that's exactly what Ms. Jackson was talking about. You have to have those conversations very early, okay? Because most people, what we see with the literature that Ms. Jackson talked about, people will think, okay, I've done bad. I'm going to get put on insulin, and I'm very quick to tell patients, good or bad. Bad is like somebody going and shooting somebody. Good is to love each other like the Bible teaches us to do. Okay, so this is not a matter of good and bad. It's a matter of, is this a high-risk decision or is it a low-risk decision? It's not good or bad. And we explain to them that insulin, when your A1C gets above 10, we need to use that, maybe not forever, but temporarily, because we don't want you to go into a diabetic ketoacidotic state and have to go into the hospital. And they get that. They understand that. And they say, okay, when they get it less than 7, they're like, can I come off my insulin now? And more often than not, we're like, absolutely. But they're starting to challenge our physicians, hey, my A1C is less than 7 now. Can I come off my insulin now? And our physicians will evaluate that, and more often than not, that creates a dialogue of what they're looking to see, and that's what the patient is self-managing their diabetes, and that's the overall goal.
Good afternoon, everyone. My name is Katy Samos. Thank you so much for sharing your time with us. And as I listen to Dr. Holloway, to Ms. Jackson, the thought comes to mind that part of this care team in some settings and becoming more and more popular is the work and the impact of community health workers. oftentimes there is also white coat resistance, as there is insulin resistance and there are adherence situations that come up due to the multi-layered factors that Dr. Holloway was mentioning. We also have the white coat resistance, and it has to do with just many years of acculturation where the doctor was the expert. So the role of the community health worker is an important one, because the role is to promote self-efficacy. And in order to be able to promote self-efficacy, and what do we mean by that? For the patient to be the driver of his or her outcomes for health, in this case for diabetes. And in this regard, they have to feel confident that they can achieve behavior change, confident in their ability to manage their different conditions, to take medications as prescribed. And oftentimes it is the community health worker who helps navigate these situations in the patient's life, as well as providing resources beyond the diabetes self-management education, resources that the patient needs in order to live a fulfilling life, in order to feel part of his or her healthcare team. So we want to partner, we want to share decisions. And as community health workers, we want to break down the barriers of care, break down the barriers that create the gap between what the pharmacist, the doctor, as patients in this ongoing open communication, and where patients really at. And as Dr. Holloway mentioned, oftentimes a pharmacist, a primary care physician, or healthcare provider lacks the time to go more in depth. What's happening in the patient's life right now that is causing the barriers that in hand create those outcomes that are difficult to manage for the patients. So as a community health worker understands the community, is part of that community, shares a language, shares a culture, it helps with reducing these barriers to non-adherence. And that's part of the role of a community health worker. Next slide, please. So in order for the community health worker to do his or her job, we need to think of, communication skills. And for these communication skills, there's one tool that in our practice we find very useful, which is motivational interviewing, where there is this spirit of collaboration, this spirit of evocation, where we're asking open-ended questions, where we're affirming where the patient is coming from, where we are reflecting and extending that which the patient shared with us, and we're able to create, as Dr. Holloway mentioned, that action plan, that goal that's measurable, that is timely, that is tailored to the patient, where the patient can succeed in his or her care. Oftentimes, when there are problems to non-adherence, the patient becomes less and less confident. And this is the bridge that the community health worker can build. Thank you. Next slide, please.
Hello, I am Dr. Best. I'm Dr. Lydia Best, and I just want to echo and add my thanks to each of you for taking part in this panel discussion, and we do look forward to your questions toward the end. I just want to talk briefly about some solutions to medication adherence. Again, I want to echo what Ms. Samos and Dr. Holloway, as well as Ms. Jackson, talked about, and I think a large part of the barrier focuses on trust. So if we could go to the next slide, we'll look at a few of the barriers that have been shown in the research. We're going to speak specifically to insulin and other injectables. So a lot of the poll questions and the panel discussion questions had to do with African American and Latino populations and Spanish-speaking populations. And when we looked at the research, as Ms. Jackson, I believe, hinted to the fact that there's little research that's done on specifically on African American and Latino populations. So this first slide is looking just briefly again at the barriers to injectable medications. And the question that comes up a lot is cost a barrier? Certainly it is a barrier, and Dr. Holloway talked a lot about the cost of some of these medications, and we'll get into that a little bit later as well. Some of the barriers in the studies have shown in the injection concerns. And then the trust issue also gets into the lack of perceived need. So some patients feel that they've met their goal, they've used alternative medicine, or they'd rather use alternative medication, or that they'd actually they don't want to use medication at all. They want to rely on the therapeutic lifestyle changes that we always encourage, but we do want to use this multi-layered approach to getting our patients to their goal. And sometimes patients are resistant to the more invasive types of interventions, such as injections. If we could go to the next slide, this next study does look at more of a diverse population. I think we went 2 slides ahead, so if we could just go back 1 slide, we'll look at 2 studies here. So this study on the left looked at about 30% African American or mixed population that was self-identified, and then almost a 30% Hispanic population. This study was done in the VA, so cost was not considered to be a factor because the medications were available to the patients for $0 or in some cases $2. This population was 98% male. The outcomes that were seen, the worst outcomes were seen in women, in African Americans, in Hispanic and other patients, especially those that were on oral hypoglycemic agents, and those that had what was considered a higher management intensity. So the more complex the regimen, the worse the outcomes were, and the outcome that was measured was the A1C. The reasons the patients gave were forgetting their medications, and Ms. Jackson alluded to delaying the medication, purposefully omitting the medication, and then in the female population, some patients admitted that they were not utilizing their insulin because they wanted to control their weight. Now, the study on the left looked at perceived barriers specifically in African Americans, and if we could go to the next slide, we're going to combine some of those barriers from African American populations as well as barriers in general. So this study looked at what strategies were thought to be effective, and I believe Ms. Samos talked a lot about motivational interviewing, and that is seen to be an effective strategy for reducing non-adherence to medication. Directly observed therapy is often utilized in HIV and tuberculosis treatment, so even though it is an effective strategy, it hasn't been utilized much in terms of diabetes treatment. In this study, community health workers were seen to have an inconsistent efficacy in terms of reducing adherence, but I do agree with Ms. Samos that they are a very, very valuable resource, especially in our patient population. So speaking from experience, we do utilize community health workers, and we have found that to be an effective strategy. Interestingly enough, some of the ineffective interventions have to do with non-human interventions. So the automated reminder call and the web-based programs did not have a human component and did not have an interactive component. And those, at least in this study, were found to be ineffective strategies. So combining what we know about some of the barriers and some of the strategies, we can go to the last slide that looks at our approach here at the Diabetes Health and Wellness Institute. We are in an urban area, an underserved area, with a 60% population, African American and Latino American population. So on the left, you'll see I combined the barriers that were found in the research in the non-diverse population as well as in the diverse population. And I tried to stratify the barriers into cost and then beliefs, the lack of trust or the lack of perceived need, and then the worries about the medication itself. And on the right, I compartmentalize the strategies that we use here at DHWI that would address those specific barriers. Of course, when it comes to the patient, we're not breaking down the approach to the patient in this tabular form. We're actually utilizing a multidisciplinary team to address multiple barriers at once. But if we can break it down barrier by barrier, what we've done in terms of addressing the cost barrier is to certainly utilize the generic formularies. And we find those formularies at not only the pharmacy that partners with our clinic, but also with the community pharmacies as well. So number one, we start with generics, and I did purposely put these in hierarchical order because I do believe that as we go down this list, the sample medications, we're actually trying to de-emphasize sample medications. We don't see that as a long-term solution. We don't see that as a viable option for most patients. There are some patients that rely on samples, but we can talk briefly about some strategies to get around that. So we start with generic formularies, and Dr. Holloway did talk about those $4 medications, and in some cases $0 copays. The next step is partnering with a local pharmacy that can offer specific discounts for our patient population, and we fortunately have that. Our office is part of Baylor Scott & White Health, and that pharmacy has partnered with us to create a formulary specifically for our patients. The next step would be the neighborhood pharmacies. The next step is to look at patient assistance programs, and the way we make that more effective is that we actually assign a liaison to help patients complete the applications. As I say, they make sure they dot all the I's and cross all the T's, and actually mail the applications for the patients after getting all the documentation from the patients and the family and the healthcare team. Without that liaison, we do see a lot of rejections from the patient assistance programs. So we don't encourage patients to do that on their own. We try to partner with them and make sure that we're going to get a yes, and we're going to get a medication supply for them within hopefully a 2-week period if we've crossed all the T's and dotted all the I's. Then in terms of sample medications, we do keep a small supply of samples, and really we utilize the samples the way most of the pharmaceutical companies expect us to, and that is to just get the patient started. What we don't like to do is we don't like to use sample medications that are expensive, that are not affordable for the patient, and that don't bridge them to one of those patient assistance programs. So if we're offered sample medications but there's no patient assistance program for that medication, we'd likely not stock that medication. There are a few patients that have trouble getting on the patient assistance programs, and usually that has to do with whether or not they have a Social Security number. The way the workaround for that is, and I'll share it with you, Lilly does allow patients to apply for their patient assistance program without a Social Security number, and we're finding that Merck does that as well. So if we have a patient on insulin that is made by a company that requires a Social Security number, we would switch them to an equivalent from the Lilly company. And then when we're looking at starting a patient on, say, an oral medication, we look in our sample closet and we look to see if we think they would qualify for that patient assistance program. And if they don't have a Social Security number, then we look for one of those companies that doesn't require that in order to provide them with patient assistant program medications. So we found that we're able to break down that cost barrier by utilizing those strategies. And then when we look at the other barriers that patients have, the main way that we approach that strategy is that interdisciplinary care team. I believe Dr. Holloway spoke about that in great detail, so I would just echo a lot of what he was saying. We fortunately have a pharmacist embedded in our clinic. We don't have a full-time pharmacist, but we have full-time access to pharmacists on site 2 to 3 days a week, and then we can reach them by phone other days, and then they can also reach out to the patients when they're off-site and the patient is at home. So a lot of those strategies do center on the pharmacist as well as the community health worker. And we do warm handoffs at the time of the patient's clinic visit. If the patient and the pharmacist are not available in the office at the same time, then the pharmacist will follow up with the patients at home. And so that's a strategy that I know isn't available everywhere, but to the extent that it is, we found that to be a very useful strategy in helping to break down some of the trust barriers and some of the education barriers, as well as the motivational interviewing that helps us to meet the patients where they're most ready for change and improvement. So with that, I'll stop so that we can turn it back over to the moderator.
Thank you. Yes, we are now open for Q&A. We do have the questions which were submitted during the registration process. However, we encourage you also to submit your questions in the question pod for any of the panelists or to gain any clarity on any topic regarding medication adherence.
Okay, thanks, Sherilyn, and thanks so much to our panel of presenters. I'm not sure what happened to Ms. Samos. Maybe her connection dropped, so hopefully she'll be coming back in soon. To echo what Sherilyn said to our audience who's here live, if you do have some questions, please submit them and we can get those answered. And in the meantime, we'll start to dive into some of the ones that were submitted beforehand. One question that comes up is, and I think Dr. Bess, I think you addressed it, but the general question is, what's the reason for the non-adherence among minorities? And I just thought maybe it'd be helpful for you to reiterate in terms of, and I don't want to pad your answer, but just approaches that are culturally sensitive, but also individualized.
Okay. Well, I appreciated the slide that when you talked about the provider barriers, and there has been studies on our providers biased in terms of their willingness to introduce insulin. A lot of it has to do with whether the provider feels comfortable with that education piece. And I thought it was very interesting, the polling question that said the provider factors were only 3%.
Yes.
So, of course, the combined factor was more than the individual patient plus provider factor. So I think we're able to admit to ourselves that the provider barriers are numerous and real. But I do believe that the trust is the most important factor that we have to consider in terms of barriers. Does the patient trust the provider when they recommend insulin? Does the patient trust themselves to be able to deliver the insulin? And does the provider trust themselves to be able to educate the patient on how best to do that? Which is where the multidisciplinary team comes in. And like I said, we're fortunate to have pharmacists. Dr. Holloway is obviously a clinical pharmacist and embedded in the clinic as well. So to the extent where that's not available, maybe Dr. Holloway could speak to some provider education resources that we can take advantage of if we don't have a pharmacist on site.
I'll take a stab at that. I think it's a multi-layered answer. Depends upon what the question is, I think, first and foremost. A great resource that we use for all of our patients that comes from Novo Nordisk. It's called Cornerstones for Care, and you fill out this form, and you get access to a CDE, you get access to a health coach, you get access to a lot of things that are offered to you from that company. And I have no financial disclosures to disclose with that. Let me just say that first and foremost. But it's a valuable resource, and that insight that they can deliver to patients is based upon their I guess you would say literacy appropriate level. Okay. So they're not going to talk over people, and that becomes an important issue that we've seen, all of us that's been practicing numerous years, is you can't talk over the head of the patient. And so that Cornerstones for Care, I would just echo that's a very important resource to use that's offered free of care. That would be my first answer. The second answer would be your health safety net clinics. Okay. Where pharmacists like myself and other pharmacists will go and volunteer our time and so forth. And really what we're starting to see specifically in the Latino community is the church has become a foundational pillar of where to go get care and so forth. And we see that. I just got back from a health disparities conference where we've seen just so many great pilot projects in Chicago, outside of Chicago, where in the Latino communities they're in the church is serving is working with the health systems to deliver different facets of care. So I don't know if that's my best answer I can give you right now.
That's very helpful, and I wish we had more time to launch on that a little bit about creating care systems for your clients. Many of us work in areas where we have a greater need than we have supply. And so sometimes you do have to get creative in the ways that you cover what your clients need. And I appreciate the Cornerstones for Care because that's something that a provider can help a client get registered for, and then just train a team member that they integrated. You can have them sit there and go through things while they're actually at the clinic as part of their education. Yeah. But sometimes, too, getting in good with your local pharmacist. Sometimes people, particularly, and I don't mean to be stereotypical, but if you're in a smaller community and you have some older pharmacists, they know a lot, and they are more than willing to share that information. So can you work something out where where they are willing to let you send your patients to have conversation, as well as pharmacy schools if they're in your area. You can get some free labor. I mean, you can help those students get some practice. That's what I meant to say.
Yeah, that's exactly right.
And do ambulatory care.
What I could value from what Dr. Bess was saying is what she's talking about is the long-term solutions here.
Yes.
So
yes.
The Cornerstones of Care is something that's always been there, and it's always going to be there, and that's not going to be like here today, gone tomorrow. Right. And the other part, though, is the Partnership for Diabetes Health Equity here from Morehouse School of Medicine. We have so many people that volunteer their time to try to reach out to people to solve those answers. So just taking a step backwards and looking at it from an aerial view, I would also echo that as well. So
Thank you. So we do have one. Go ahead, Kati. I'm sorry.
Thank you. Another resource is the National Diabetes Education Program, where it has many resources for patients in different languages, depending where they live in the United States or Hawaii. And that's a very good resource also. It's part of the National Institutes of Health.
Yes. Thank you. I think we do have a question from the audience that we want to try to get in before we're right up at the hour. Wow, where'd the time go? So, Sherilyn, could you read that question for us?
Absolutely. We have a question from Constance. She would like to know, do you think having forms of incentive could be a means to increase adherence?
One thing that we have, I don't know if you would call it an incentive, but in terms of having patients self-monitor, which is very important when they're taking insulin or other injectables, is we have the ability to give free testing supplies, including the strips for patients that bring in their meter. So we do find that very effective. I'm not sure if you would call that an incentive.
Yeah, one thing I would like to address with that is depends upon how you define incentives. But if you look at anybody that's been involved with diabetes education out there in the community is going to know what I'm saying with this. But the ADA Standards of Medical Care says, you know, we need to DSME is a grade A recommendation, and a part of that we need to talk about the psychosocial adjustments as one of the pillars of that, and one of the specific granular pieces of that is positive feedback recognition. And so what we do in terms of our minds, the way we learn, they're developed to they learn off positive feedback. So what we try to educate our patients when they come to our group diabetes visit is when you look at that fasting blood sugar every day, and if it's between 80 and 130, the fact that you took your metformin and the fact that you planned your meals and your carb counting, that is what you did. You did that work. Nobody else did that for you. You did that for yourself, and they really get incentivized because they know I did this by myself. My disease doesn't define me. I define my disease. And so what we find is that is probably the best incentive that our patients provide as feedback to us. And then when they look at their blood pressure, when they take that throughout the week and they're monitoring that, the same thing, and then their A1C when they come in, same thing. So.
And I'll just piggyback to one of the things that one of the teams I've worked with over this past year that they did is that they have diabetes champions. And so a person that they will highlight or spotlight either in a newsletter, on a bulletin board, or even as a sort of a patient liaison if they need, if they have other patients that may be having some difficulties or having some trouble with motivation, then they will use these clients as a spokesperson for how they've triumphed, or just to celebrate some of their personal successes. And that's worked very well in terms of encouraging people just in the fight or in this journey, but also to use it to encourage others that they want to try to be like them. It's the same principle that works for kids. So you have a spelling champion, you can have a diabetes champion.
Yeah, and that brings up a great point, because in the South, what we see with African Americans is the church sometimes serves as that diabetes champion. And it does it very well. And there's been numerous papers that have been published on how that has helped not just one person, but congregations of people. So.
Yeah, absolutely. Well, Sherilyn, we are right up at the hour, so I will turn it over to you.
Thank you, Dr. Holloway, Dr. Bess, Ms. Shamos, and Ms. Jackson for a very informative and educational presentation. Additionally, we thank each participant for attending today. As previously mentioned, you will be able to access all the content that was shared during today's webinar, in addition to the past 3 webinars, by accessing primarycarematters.org. You will have access to the webinars, you will have access to the requested resources. The newsletter series will be available on the website, in addition to an opportunity to innovate and collaborate with like-minded professionals via the NCPC virtual learning community. And this concludes today's webinar, and we thank you for attending.
Thank you.
Thank you.
Thanks, everyone. Have a great afternoon.